I'm Sahar El Arab, consultant of the Early Cancer Detection Unit, consultant for public health. The Early Cancer Detection Unit was established in 1981 by Professor Dr. Mohammed Samour. The unit started by performing cytological examination of both gynecological and non-gynecological specimens, as well as gynecological pathological evaluation. We are greatly indebted to Dr. Mohammed Azzuddin Azzam, Professor Mahmoud Al-Shurbagi, Professor Mahmoud Yusuf, Professor Magdi Kamal, Professor Hatem Saad, Professor Muhammad Amer, Professor Amr Al-Husseini, and Professor Mohammed Al-Sayed for their steady support for us. We extend our gratitude to our unit co-worker for their help, and a great appreciation for Dr. Hala Salali and Dr. Amal Aloub for their assistance in editing the medical data, and special thanks to Dr. Zainab Shihabuddin. The cytology and pathology for gynecological pathology is introduced in 1981. Colposcopic and hysteroscopic examination were introduced in 1985 and 1986. Then fine needle aspiration technique began in 1991, and liquid-based cytology on 2023. We have 360,000 procedures over a period of 41 years. The mission of the Early Cancer Detection Unit is to promote excellence in the practice of early cancer detection of the female genital system. The Early Cancer Detection Unit vision is to achieve the highest quality standard to lead early cancer detection service in Egypt and the Middle East. In 1962, we started the data management on Ashton TED database 3 program, then on database 4 programming. In 1995, with the innovation of Windows and Microsoft Access, I designed a program on Microsoft Access to store all data of all procedures on a certain program for Microsoft Access. We update the design, and then in 2023, the system will be integrated in the electronic medical record of the hospital. As for coding, for pathology, both diagnosis and intervention code were assigned by local unit codes with reference to Bluestein pathology of the female genital tract in association with the International Classification of Disease of WHO. For cytology, the BESISTA system, a reporting system, was used. We have a total number of 360,000 procedures in early cancer detection unit over 41 years period, with pathology and cytology have the highest percentage. We have analysis of this on the software program. We can search by diagnosis or by categories, or list of patients with specific selected diagnosis, or all diagnoses per year. This is an example of display of the results of cytology in a specified period for cell abnormalities according to BESISTA system. And this is an example of cervical histopathological finding according to category in pathology per year. And we can select a specific diagnosis and have a list of this diagnosis for all patients, but I hide the name for confidentiality. As for cytology, we have 102,635 smears. Over the 41 years, we have an average of 3,600 patients per year. Almost of patients perform more than one procedure. According to BESISTA system, the results of this 41 years, we have a 95,120 satisfactory samples, with abnormal cells representing 5.4 out of these samples. With low-grade SIL have the highest percentage, followed by the atypical squamous cells. Early in 1991 and 92, the terminology of CIN 1, 2, and 3 was used. Then after SIL terminology is accepted in 2004, all the cytological specimen performed, we shifted to the use of the terminology SIL. The drop of percentage of CIN in the early years is due to the fact that the hospital served to some extent the same catchment area of the hospital, and we started with unrecognized cases, then we are left with the incident cases. This is the time trend of the low-grade SIL and high-grade SIL over 41 years. On comparing each 10 years period, there is a rise of the low-grade SIL in the last 20 years. Of abnormal cervical cells, 80% with low-grade SIL. Then a typical squamous cell is 7.3 and high-grade SIL is 4.4. On comparing the mean age in the different group of cell normal and abnormal cells, the low-grade SIL show a significantly older age than the normal cells and a younger age than other abnormalities detected. On analysis, on cytology-based analysis, the low-grade SIL on condyloma, we demonstrate a high rise in group 31 to 40 and group from 41 to 50. But CIN1 show a steady curve and increase after 50 years. The rate of abnormal cells was found to be higher in cases with routine checkup than in symptomatic cases, and this focuses the light on the need for a screening program. As for pathological examination, we have 135,958 specimens over the 40 years. Endometrial biopsy represents almost 50% of cases and hysterectomy 20% of cases. Out of the finding of uterine body in pathological evaluation, out of 101,667 specimens, we have a precancerous lesion representing 11%, with endometrial carcinoma 3%. And out of 37,400 specimens of cervical finding, the precancerous lesion represents 14.8%, and the malignant tumor is 4.6%, with squamous cell carcinoma showed the highest rate out of malignancy. For ovarian pathological finding, out of 29,805 specimens, we have a borderline tumors less than 1%, and malignant tumor is 5.4%, with malignant serous epithelial tumor showed the highest percentage of malignant tumor. Out of all malignancy encountered in early cancer detection unit, endometrium or the uterine body shows the highest percentage, followed by the cervical, then the ovarian. On comparing the malignant site, the cervix showed a higher percentage than endometrium and the ovaries in the first 10 years, and this rate is inversed in the last 15 years, with the endometrium higher than the cervical. Out of all cases, of pathology, 108,000 cases. We have 6% malignancy and 13 pre-malignant cases, with the cervix representing 6%. Data is a precious thing and lasts longer than the systems themselves. That's why we recommend that medical record and medical documentation is very important for the continuity of care of patient and for research. Thank you.
Thank you very much. Can I just ask one question? Why do we think there is an increased rate of LSIL in the last few years? One of your graphs showed quite a steep rise of LSIL compared to others. Do we know the reason for that? Is it because more women are coming forward and the screening is better, or is there a definite incidence increase?
There is increase because they increase the screening for routine cases and take a routine smear from the clinic and from many other parts other than the symptomatic cases.
Thank you.
Thank you.
Thank you for that. So can we now please move on to introduction to cervicovaginal screening, interpretation, tips and tricks. Professor Magda Hassan, thank you.
Good afternoon, everybody. I'm really glad to be among this wide group of clinicians and as well eminent chairpersons. And I'm really glad that my students whom I taught in the third year became now doctors, and they are attending with us this session. So I'm very glad for that. Well, I'm going to throw some light on the cervicovaginal smears and their interpretation and in relation to colposcopic findings. First, I will start, how can we get rid of cancer cervix? According to the WHO recommendations in 2020, they launched a strategy for the global elimination of cervical cancer through national cervical cancer control plans. And there were three main points for this elimination. First of all, 90% of girls receive the HPV vaccine by the age of 15. Vaccinated women are also recommended to go on through the screening program as well. If she's vaccinated, this doesn't mean that she doesn't do her pap smear. No, she has to do her pap smear regularly as the non-vaccinated woman. The second point is that, I want to go back. It's going forward. Let me go this way. No, I don't. How can I go previous? Please, how can I go to the first slide, second slide? Yes. Yes, and the second was that 70% of women receive cervical cancer screening by the age of 35 and again by the age of 45. Okay, and now coupled with the vaginal smear, there is the HPV testing, especially HPV 16 and 18. So with the cervical smear, this is called the cervical triage. The third point is that 90% of the diagnosed women with precancer or cancer diagnoses receive their treatment. Hopefully, this could be fulfilled by 2030, as the WHO recommends. Now, skip. Yes. As we all know, the cervix is the gateway to the uterus. The cervix is the barrier of infection to the body of the uterus, permits the escape of menstrual flow capable of dilating to accommodate childbirth. This is the beautiful cervix that we want to look for, whereas the other side is the ugly-looking cervix with carcinoma of the cervix. Now, as we all know, what are the risk factors for cervical cancer? On the top of the list is the HPV virus. Then come other factors like multiple partners, like smoking, and as all cancers, they always put dietary factors if present. Now we will focus on what we call the transformation zone of the cervix, أو منطقة التحول. This transformation zone is very important to be examined and to be sampled in the cervix. The transformation zone simply is defined as the area of newly formed squamous epithelium. It was columnar and then changed to squamous epithelium. So the area in purple, the area here colored in purple is the one what we call the transformation zone. And as I always say, I give you an example. If I get two persons, one is walking and one is running, and I put an obstacle in front of them, both, who will be damaged more? The one who's walking or the one who's running? Definitely the one who's running. So this area where we had columnar and changed again to squamous is the site of entry of HPV, is the site where we are looking for dysplasia or CIN. Okay, so this, whenever we do cytology or colposcopy, should be sampled. Again, what are the boundaries of this transformation zone? The boundaries of the transformation zone, starting from the squamocolumnar junction here to the distal cervical crypt opening. The last opening of the glands will be the outer boundary of the transformation zone. Mind you that sometimes there is difficulty in seeing the transformation zone. For example, in cases of menopause, in atrophy, the transformation zone is inside the canal. Again, in pregnant women, because we cannot sample the endocervical canal in pregnancy, and sometimes in young nulliparous women. How do I know that the smear you have sent to me has sampled the transformation zone? So not any squamous epithelium will come to me, I will interpret, but I have to focus on two important cells to know that the transformation zone is sampled. The first of all is the endocervical cells. And enough if there is one group, this will be satisfactory for me to know that the transformation zone is sampled. As you see, the endocervical cells have a honeycomb appearance, very characteristic for these endocervical cells. The next cell that should be apparent when you sample the transformation zone, what we call metaplastic epithelium. The metaplastic epithelium means changing of the columnar to the squamous. But this is not like switching in a minute. Of course, it takes some time to change from columnar to squamous epithelium. These are the two cells that represent the transformation zone in our pap smear. What is the problem with the immature squamous metaplasia? Sometimes when you do colposcopy for an area with immature metaplasia, the epithelium here is in between, has both characters of the columnar and the squamous. So falsely, it can have an aceto-white color after application of acetic acid. So you can send the biopsy from this area and say this is a biopsy from aceto-white area, okay? And of course, we'll be minded for this aceto-white, but it is a cause of a false negative result in cytology, okay? There is a difference between the aceto-white of immature metaplasia and the aceto-white of actual CIN or dysplasia. Indications for pap smear, on the top of the list are the routine screening, but we don't actually have routine screening now, in spite that there is, I think, a presidential initiative for screening of women as a part of the women health care. Again, we need it for follow-up after subtotal hysterectomy for the risk of stump carcinoma. We used to make for hormonal study, but now ultrasound has carried on with the hormonal study and evaluation of ovulation. We used to make it for studying irradiation on the cervix, but Dr. Manek recommends that in UK, they don't do any more pap smear for irradiation. Follow-up for immune-suppressed women. Other indications, women with current or prior HPV infection, women with current or prior herpes simplex infection, women with a history of other STDs, and those who are having HIV infection. And Dr. Manek recommends that those who are having HIV infection, they should have yearly pap smear, every year, pap smear. Smoking and other abuses like those drinking alcohol. Any woman who has a history of cervical dysplasia, endometrial, vaginal, or vulval cancer, she should also have a checkup by the pap smear. What are the, look at these ugly looking cervices from infection, whether those having Monilia, the strawberry cervix of the vagina, and I would like to say a word here. The cervix here in having this trichomonas infection is like the strawberry, has red spots. For those who make colposcopy, and you know this quite well, don't misdiagnose it as punctation because we didn't apply acetic acid. Okay? Atrophic cervicitis, those cervix actinomyces, and herpes simplex look worrisome, especially if there is resistance to treatment. So these have to be checked with the smear. Another indication for a pap smear is the presence of leukoplakia. Presence of leukoplakia, as you all know, leukoplakia is a white patch on the cervix, and it is usually raised above the cervix. In spite that the lesion is not worrisome, but there may be underlying pathology under it. So she should be examined, and if in need, a biopsy should be taken from this leukoplakia. So let us see the test requisition. The minimal clinical data that we need in the sheet, our request of the pap smear, is the age of the patient, the date of the last menstrual period, or the date of her onset of her menopause, past or current history of any abnormalities or treatment, pregnancy status, and if she's a smoker, the parity, of course, is important, and the family history, if there is any history of carcinoma for this family. Again, other symptoms that we need to ask about, the presenting symptom, there is backache, leukorrhea, contact bleeding, dyspareunia, dysuria. All these should be asked. One of them could be a symptom of early carcinoma of the cervix. Before the pap smear, she should not be having douches, should not be using lubricants, and this I think we know. There are so many designs for spatula, and of course this plastic brush is less traumatizing, less bleeding if she is having an erosion or something, and we focus the long part here in the external os and rotate this part 180 degrees. By this way, we are going to sample 3 areas: the endocervix, the transformation zone, and the ectocervix on the glass slide. Okay, here we are by sampling. This is the wooden spatula. We are taking cells from the 3 areas that we want to target in examination of the cervix. As regards the processing, we all know we have the conventional method by the Papanicolaou stain, and now recently we have the liquid-based cytology that we have introduced recently in the unit of early cancer detection. It gives better visualization, it eliminates the debris and the inflammatory cells, give a clear field and better diagnosis. Simply, the liquid-based cytology is the study of cells through a liquid medium, and then transformed into a bottle so we can have a stock for other ancillary techniques. Here we are. These are the steps where we are having rapid movement and then negative suction to pick up the cells and then putting them on the slide. As I mentioned, these are, if you compare, this will be the slide of the conventional, definitely taking a longer time, and this will be the slide prepared from liquid-based cytology. Now the system that we use for interpretation is the Bethesda system. The Bethesda system has focused on more than one point. First of all is the adequacy of the specimen. You don't interpret on an inadequate specimen. And this is the way to minimize the false negative results of cytology. False negative result in cytology is a serious mistake. It might delay surgery at time when cure is possible. So this is serious. Okay, let me give you a situation. Say I said this lady is having low-grade squamous intraepithelial lesion, and she proved by biopsy to have a higher grade, or what we called in the past moderate dysplasia. Is this a false negative fully? No, it's not a false negative. Discrepancy can occur between histology and cytology. Histologic diagnosis is a pattern diagnosis, while cytology depends on the exfoliated cells. Bethesda helped the clinician in planning the treatment just because it makes 2 groups only, instead of in the past CIN1, CIN2, CIN3. Now it is clear and crisp to the clinician. Low-grade SIL and high-grade SIL. Okay? So this is important for the clinician, clear in his mind the low grade is less dangerous and the high grade needs to be treated. And it has put 5 components for evaluation. First of all, as I mentioned, very important, the adequacy of the specimen, general categorization, interpretation, and adjunctive testing if needed. And again, they introduced new terminologies, like what we call ASCUS and ASC-H. And yes, I want to focus on the specimen adequacy. It means satisfactory for evaluation if we have well-preserved squamous cells. The number of cells on the slide, the minimum 8,000 and the maximum is 12,000. But if I find abnormal cells in the smear, I have to report, even if the smear is unsatisfactory. I have to report, and because these abnormal cells are very important, and I shouldn't leave them because that I don't see endocervical cells, for example. No, we have to report them. Now, these are the variety of cells that we see on the squamous side, starting from parabasal, intermediate, and superficial, and the columnar cells or the glandular cells that could be present in the smear, endocervical cells or endometrial cells. I don't bother you with this. Now, let me have the word with this is the ASCUS, or atypical squamous cells of undetermined significance. What is more important, again, in the low-grade SIL, that it included the CIN1 in the past and the HPV infection. And of course, HPV should be quite and accurately diagnosed in the smear because it is included under the low-grade SIL. And you can see here the pictures by colposcopy for the presence of HPV infection. And if they progress, they will do more lesion. The HPV penetrates the epithelium until it reaches the basal layer and then enters inside the cell and start to cause squamous abnormalities, especially with high-risk types of HPV. The pathognomonic cell for HPV is the presence of koilocytes. The characteristic cell, as I mentioned, the koilocyte, is not only the problem of a vacuole, it should also have nuclear abnormality here as well. The differential diagnosis, as not to go to erroneous diagnosis of koilocyte and tell the patient you have HPV, not any halo in the cytoplasm is a koilocyte. There could be some small perinuclear halo with any other infection. But the koilocyte should be a large vacuole. In high-grade SIL, the point of importance, and my last point, is that any woman above 40 or 45 having glandular cell, especially endometrial cell, in the smear, it should be reported, even if they are normal endometrial cells, because this means that there is a definite endometrial pathology. Either she has a polyp, either she has hyperplasia. So if we find them in the smear, in a woman age 40 or 45, we should report. Thank you very much for listening.
Thank you very much. I think you were attempting a very big lecture in a very short time, but it was a good. Thank you very much. So following on from that, naturally, we need to know a little bit more about HPV genotyping. So please may I ask Dr. Omnia El-Nabawi to come and talk to us about an overview of molecular detection of HPV. Okay, so we might have to move on to the final one, and then maybe come back to the HPV detection. So please can I ask Dr. Salma Tarek Mahmoud Hafiz to talk us through the Bethesda system, which Professor Magda Hassan had already started to tell us about. Thank you.
Good afternoon. Today we are going to talk about the Bethesda reporting system for cervical cytology. Cervical cancer was previously one of the leading causes of cancer health in women worldwide. However, its incidence mortality have markedly declined in the past several decades due to the following. The success of cervical screening practice, the standardization of Bethesda system for reporting cervicovaginal cytology, improvement in the understanding of the human papillomavirus pathogenesis in cervical cancer, the development of appropriate management approaches. The history of Bethesda system for reporting cervical cytology goes back almost 3 decades. The terminology was named after the location of the workshop in Bethesda, Maryland, USA. The process that created it had a profound impact on the practice of cervical cytology for laboratorians and clinicians alike. The 3 guiding principles for Bethesda system reporting cervical cytology are the classification terminology of cervical smear. Report should be uniform, reproductive in different laboratories worldwide, flexible to suit local population requirements. The cervical smear report should provide clinically appropriate and relevant information to the treating clinician. The terminology used in the report must be periodically updated in order to reflect the present understanding of cervical cancer. Bethesda 2014, why we need it? The past decade has witnessed several changes in the realm of cervical cancer screening, prevention, and management. This includes the increased use of liquid-based cytology, the addition of co-testing, PAP, and high-risk human papilloma testing, primary high-risk human papillomavirus testing as additional screening report. Further insights in human papillomavirus biology, changes in histopathology terminology. Approval and implementation of prophylactic human papillomavirus vaccines. Updated guidelines for cervical cancer screening and clinical management. On this basis, all of these changes, 2014 was an appropriate time for a review and update of the Bethesda 2001 terminology and for the 3rd edition of the Bethesda Atlas for Cervical Cytology. The major changes in the Bethesda 2014 included the following: reporting of benign appearing endometrial cells for women above 45 years old instead of women 40 years old. No new category was created for squamous lesions with LC and few cells suggestive of concurrent high SIL. The term low-grade squamous intraepithelial lesion cannot exclude high-grade intraepithelial squamous lesion is not recommended, maintaining the 2-tiered classification scheme. This is the Bethesda reporting cervical cytology. The first 2 versions of Bethesda terminology include 3 categories of adequacy: satisfactory, unsatisfactory, and borderline, but limited, less than optimal, and renamed satisfactory but limited by in 1991. The 2001 Bethesda system eliminated this borderline category because it caused confusion among clinicians and for the appropriate follow-up for such cases, variability in criteria used to report satisfactory but limited by among laboratories. To provide a clearer indication of adequacy, specimens are now designated as either satisfactory or unsatisfactory. Unsatisfactory, this category includes, first of all, we have to say to reject or accept the specimen. We can reject the specimen if there is problem in the labeling of the name of the patient. Anything is not matching the slide of the specimen with the information of the patient, this specimen should be rejected. If it is a slide If it was broken and we cannot read it, it must be rejected. Specimen processed and examined, but are unsatisfactory for evaluation of epithelial abnormality. The latter represent the most common clinical scenario. We have to have minimum squamous cellularity criteria, endocervical transformation zone component, no obscuring factors, no interfering substance. For the minimum number of squamous cellularity criteria, a woman with a cervix should have an estimate of minimum 5,000 in cells, well visualized squamous cells. This 5,000 for the liquid-based preparation, 8,000 up to 12,000 in the conventional preparations. The endocervical and transformation zone, the presence or absence of them must be included in a comment. Obscuring factors, often observed if more than 75% of the squamous cells are obscured by the inflammatory infiltrate or anything obscuring factors like blood also. Interfering substance like lubricants, and like Dr. Magda said, this must not be used during having the smear. Excessive bloody specimen and air drying artifact. The report should clarify whether the presence of blood, mucus, lubricants, inflammation, or technical artifacts contributed to the unsatisfactory sample, or whether the problem was simply due to low squamous cellularity. What about transformation zone? The presence of transformation zone sampling is not necessary for an adequate specimen. Only squamous cells are necessary. But I have to report them. For conventional and liquid-based preparation, an adequate transformation zone sample requires at least 10 well-preserved endocervical or squamous metaplastic cells singly or in clusters. In 2014, Bethesda system update still recommend reporting the presence or absence of them, even though the absence of an ectocervical endocervical transformation zone component should not lead to early repeat screening. يعني المفروض لا في الريبورت بتاعي لما نكتب ان انا ما عنديش endocervical وهي satisfactory او فيها lesion، هو مش المفروض يعيد to repeat early the screening، هيمشي على الschedule. If a clinical care provider only rarely or even obtains endocervical zone transformation zone component in a population of women, including those in the childbearing period, يعني مش عندهم atrophy, okay? This indicate there is an issue في sampling بتاعه. فلازم to get يعني to investigate اللي بياخد السامبلز بتاعنا مش بيعرف ياخدها كويس، ودي حاجة quality indicator. طيب satisfactory material diagnostic categories either negative for intraepithelial lesion أو malignancy. With this diagnostic criteria applied to cases with non-neoplastic cells, either inflammatory cells. Epithelial cell abnormality in conventional and smear and liquid base. The two components, either squamous cell or glandular. In squamous, we say atypical squamous of undetermined significant ASCUS. A typical squamous cell cannot exclude high grade ASC-high, low grade squamous intraepithelial lesion, high grade cell, squamous cell carcinoma. The glandular cells, atypical endocervical, atypical endometrial, atypical glandular, none otherwise specified, atypical endocervical cells favor neoplastic, atypical glandular cells favor neoplastic, endocervical adenocarcinoma in situ, endocervical adenocarcinoma, endometrial adenocarcinoma, extrauterine adenocarcinoma, or adenocarcinoma not otherwise specified, or other malignant neoplasm. The Colleague of American Pathologists reported the 50th percentile rate for unsatisfactory specimen in US laboratories, 1.1 for conventional, 1.6 for thin prep, and 0.3 for SurePath in 2022 survey. Management, what are the management guidelines related to adequacy? A risk-based management consensus guidelines updated in 2019 recommended for the management of women with unsatisfactory cytology, a repeat cytology after 2 and 4 months for unsatisfactory cytology. Colposcopy is recommended for 2 consecutive unsatisfactory cytology results all women who are known to be human papillomavirus 16 or 18 high risk positive with unsatisfactory cytology. For women who received radiation chemotherapy, hysterectomy, or trachealectomy for cervical cancer, these patients often develop atrophy and the cervix may become stenotic. A lower threshold of 2,000 cells in these patients can be considered. And our professor told us that patients having radiation are not candidate for pap smear. Management of women with cytology reported as negative but absent transformation zone for aged 30 years and older and for 21 to 29 years old. For the older, high-risk human papillomavirus testing is preferred when cytology is reported as negative with absent transformation component. If a high-risk human papillomavirus test is negative, routine screening interval is recommended. Repeat cytology in 3 years is acceptable in high-risk human papillomavirus testing is not performed. Routine screening is recommended for patients 21 to 29 years old. Routine screening is recommended when the cytology report is reported as negative with absence of the transformation component. High-risk human papillomavirus co-testing is not indicated in women aged 25 up to 29 years. However, some women in this age group may elect to undergo high-risk human papillomavirus primary screening using one of the FDA-approved testing method for patients in the United States. This is a comparison of the current and previous American Cancer Society guidelines. الage كان مختلف. 2012 كنا بنعمل cytology alone every 3 years starting at age 21. الجايدلاينز الجديدة بتقول age أكتر من 25 years old, less than 25, no screening. 25 up to 65 years starting at the age of 25 هيعمل primary human papilloma virus test alone every 5 years. احنا كان القديم ان احنا بنعمل cytology alone and every 3 years until age of 29. Co-testing every 5 years or cytology alone every 3 years are acceptable option. Co-testing and cytology or cytology testing alone are accepted where access to primary human papillomavirus testing is limited or not available لأنه مش موجود في كل مكان. For management of positive result and subsequent surveillance هنلاقي الجايدلاينز في 2020. aged أكتر من 65 years old هنعمل discontinuing للscreening if adequate negative prior testing. After hysterectomy, individuals without a cervix or without a history of CIN2 or more severe diagnosis in the past 25 years, cervical cancer ever should not be screened. طب what about the human papillomavirus vaccinated patient? They follow up. Age-specific screening recommendation same as unvaccinated individuals. Thank you.
Thank you very much for this swift introduction to Bethesda system. I know very little about it because, as you know, in UK we only use the UK system. But it's interesting to know that in many ways Bethesda seems to be following UK's guidelines a few years later, and especially when they've only recommended some changes in 2020. Yes. But the nice thing is that, you know, using the Bethesda system here, you are along the rest of the world except UK, United Kingdom, which is very good. And can you just say that are all the laboratories here completely familiar with the Bethesda system? And in Egypt, I mean, not just in Cairo.
المعلومة دي أنا مش عندي. They are familiar with the Bethesda system here in Egypt. We have some problems in the interpretation.
Yeah.
Sometimes we have the doctors asking about details in the Bethesda. We are trying to give a detailed report to fulfill all the points and to decrease the inquiries about the Bethesda.
Yeah. The reason I asked that was because one of the slides that you showed, it's a very long list of abnormalities, isn't it?
Yes.
And even the subdivisions between atypical glandular cells,
Yes.
NOS, and then atypical glandular cells, favor neoplasia, it's very confusing like that.
Yes.
But I think any training that you can give to the rest of the laboratories in the country, I think that would be very, very useful to standardize things.
Yes.
So that's the ultimate aim for Bethesda, isn't it? To standardize reporting.
We are trying.
Yeah, thank you very much.
Thank you very
Wonderful.
much.
Thank you. So we do have our fourth talk on the overview of molecular detection and genotyping of HPV in cervical specimens. So Dr. Omnia El Nabawi, please. Thank you.
I would like to thank the organizing committee for inviting me to tell the lecture. I'm going to give a lecture about an overview of molecular detection of and genotyping of HPV in cervical specimens. My outline, I'm going to talk about an introduction and I'm going to talk about molecular methods and the clinical utility of human papillomavirus molecular detection. First of all, I would like to give a brief introduction about human papillomavirus from the point of view of microbiology. It is a double-stranded virus, DNA virus, and it is one of the most common sexually transmitted diseases. It is worldwide and causes severe infections in transplant patients. It infects basal epithelial cells of keratinized skin, mucous membrane, and the transformation zone of the cervix, and is associated with cervical and anal cancer, as well as cervical intraepithelial and anal intraepithelial neoplasms. And I'm sure that you have known about this in the previous lecture. It causes also a proportion of valvular, vaginal, and pineal squamous cell cancers. It has a role in head and neck cancer, and certain types can cause cutaneous and anogenital warts, which are of low malignant potential. About the genotyping of human papillomavirus, we have 118 genetically distinct types of human papillomavirus. We differentiate them briefly as high risk and low risk. High-risk viruses, there are 19 strains. The most important is 16 and 18, and we have 9 low-risk types, including 6 and 11 and 14 and etc. It has a tissue tropism for cutaneous and mucous membrane, as I said before. And what is a tissue tropism? It loves to go to cutaneous tissue and mucous membranes and causes a malignant potential. What about the genome organization of the virus? The genome organization of the virus, I like to use this picture, and I hope it is clear. The most important part is L1, which is coding for L1 gene, which codes for major capsid protein, and L2, which codes for minor capsid protein. We're going to use them in our molecular detection, so they are very important. And the most important oncoproteins is E7 and E6. And E is for, I will go for the previous slide, that the E is codes for the early gene. The early gene codes for E, and E regulates the viral replication, and some have transforming potential. So they are the most important proteins. The oncoproteins is E7 and E6, which regulates the replication, the viral replication. Okay. human papillomavirus genome is maintained in non-integrated epithelial forms. In cancers, it goes into integration. It integrates, the virus integrates itself into the host genome, suggesting that this integration is important for malignant transformation. This is the E7 and E6 proteins, and this I like to use this figure as well because it explains the role of E7. It inhibits the PRP, so it goes for deregulation of cellular proliferation with a malignant potential, and E6 here blocks the apoptosis of P53. Okay, degradation, and so it promotes outgrowth or overgrowth of deregulated cells. Okay. However, only infection with human papillomavirus itself is not sufficient for causing cancer. For example, interaction of human papillomavirus with human keratinocyte itself don't cause cancer. Trans-infection with a muted RAS gene results in a full malignant transformation. In addition to the genetic factor, there are other risk factors like smoking, microbial infection, dietary deficiency, and hormonal changes are all implicated in the pathogenesis of cervical cancer. The diagnosis of human papillomavirus. Human papillomavirus cannot be grown in cell culture. We know that the viral detection mainly relies on either a cell culture or serology or a PCR. But unfortunately, human papillomavirus can't be grown in cell culture easily, and serological assays have only limited accuracy. As infection with human papillomavirus is followed by humoral immune response against the major capsid protein, which we denoted previously, with antibodies remaining detectable for many years. So it is not an accurate diagnosis for an active infection. And it is not suitable for distinguishing present and past infections. Accurate diagnosis of human papillomavirus infection depends on detection of viral nucleic acid. And as we are going to see, this is the summary for the diagnosis in general, incorporating all the methods with the big sensitivity and specificity for B16 immunohistochemistry. And as well as here we have the E7 and E6 here, messenger RNA in situ hybridization with high sensitivity and specificity. And we have the ONCOS E16 a limited much higher sensitivity and specificity. And what about the molecular detection? The molecular method comprises in situ hybridization, DNA hybrid capture, and PCR on clinical specimen. And it is recommended for women as co-testing. And what is a co-testing? Co-testing is doing cervical pap together with PCR. It has a strong recommendation. What about the sample collection? We collect samples like cytology and, for example, cervical scrapping. We can do cervical scrapping or swapping. And of cervical epithelium is used for DNA isolation, which may cause sample error and inconsistent results. And it also depends on the ministerial cycle. Stability of sample during storage and transport is also important for false positive results that may occur due to nucleic acid degradation by endonuclease. So we have to take care about storage and transport so that we lower or decrease the chance of false negative results. And here is the main theme of the lecture, the polymerase chain reaction, which is the base of the molecular detection. The polymerase chain reaction is a method that allows logarithmic amplification of short DNA sequences within longer double DNA strands. It is so sensitive that we can amplificate a single DNA molecule and can get a lot of copies from it. Briefly كده, we do amplification of the DNA so that we can detect it by various methods. We do it in these machines, which is a light cycler or thermal cycler, and we going to know the exact method. What is the principle? we can, first of all, the principle of PCR. This is the basis that first we have double-stranded DNA, which is our target. This is at 50 degrees. We rise the temperature to 50 degrees. And we can see here that the separation of the two strands starts to occur. Okay? Then rising temperature to 95, the step of denaturation starts. Here we can find that we separated the two strands. Then the next step is decreasing the temperature to 55 and annealing of primers occur. And what is the primer? The primers, the target that we put, this is our kit. We put primers specific for human papillomavirus. So this primers goes to anneal, يعني, get attached to the strands. And the next step is that the polymerase, which is also in the kit, it is an enzyme that binds the primer and extends it in that way. So the primer has been the main point or the cornerstone, and we have extended to the strand to make two copies, okay? And this forms one cycle of DNA synthesis, and it occurs at 72 degrees. And this is why the machine is called a thermal cycler, because it uses heat to separate and anneal the, the strands. Okay, again, we do the same cycle again. We raise the temperature to 95. So denaturation of the original strand and the new strand, okay, with more and more amplification and extension of new strands. So the process of denaturation, annealing, and extension is repeated numerous times in the thermal cyclers. Getting at the end of each cycle, each newly synthesized DNA sequence, as we saw, the two new strands, acts as a new target. This is our new target for more amplification, which result in accumulation of specific PCR product. What does it mean specific? Specific for the target gene. As we intending to detect a human papillomavirus, it will going to be the specific PCR product is human papillomavirus. After 30 to 40 cycles, millions of copies of the original target DNA are created. This is the first part. It was the amplification, how we amplify and increase the number of copies. The second step is the method of detection. The method of detection is very crucial because it differentiates the conventional PCR, the old type PCR and the new type PCR. The conventional type PCR used the gel for detection and a kind of dye like ethidium, which is a weak dye, and it has many disadvantages. What I'm showing you now is the real-time PCR method of detection. This is method of fluorescence. It detects the PCR products by fluorescence. And how can we get that fluorescence? By one of these four types. The first one is by using cybergreen. Cybergreen is a dye, is a very powerful dye that when the product is in a single strand, it doesn't combine to it. It combines only to double-stranded type, and then as we see it fluoresces. And we can see it by the camera. The machine contains a camera which measures the intensity of the cybergreen and relate this to the quantity of the original target. The second type, we can use the Tachman. The Tachman technology is by using this primer. We put this primer. This is R denotes for the reporter, and this is for the quencher. And I'm going to show you to show you an animation for it as well. The reporter is dim and the quencher is lightly clear, because as long as it is in a single strand, it will not emit fluorescence. As long as the Tachman comes and extends the strand, the quencher is separated from the reporter, and the reporter starts to emit fluorescence so that to be detected by the camera in the machine. And here is the molecular beacons, which is like a hairpin. Okay, when they are the reporter and the quencher, they are near to each other. They don't emit fluorescence, but when they are cut by the polymerase enzyme, they are apart from each other, and the reporter emit the light, and the machine measures it by the camera. And here it is, an animation. Here is the first step where polymerization occur, and the R for the reporter and the Q for the quencher. The quencher inhibit the fluorescence as long as it is near to the reporter. And this is the Tachman enzyme, which extends the strands, and it extends the strands. So strand displacement occur. Then cleavage, we cleaved the reporter away from the quencher, and it starts to emit fluorescence. And then the strands completed and the polymerization completed, and we measure the copies by the quantity of fluorescence of the reporter. And here is the method of cyber-green chemistry. We use the dye, and we said that when the dye is surrounded by single strands, it doesn't emit any fluorescence. Then when the Tachman or the strand extends, it goes like this and emit fluorescence, which is measured by the dye. Okay, it's a kind of a sophisticated graph about how it is detected, how the PCR in log phases, and this is the DNA, and this is the cycles, and as we see that it is directly proportional. Whenever the cycles increases, the DNA logs with amplification increases and then goes to a plateau, okay, which we can detect the any kind of emission like Ethidium gel or cyber green. Okay. This is the first part, is how can we detect a positive or negative sample just by fluorescence. The second part is how we quantify the copies by real-time PCR. I will go fast because it's only 5 minutes. And the real-time PCR, احنا قلنا إنه it uses fluorescence emissions, and the most important part for quantification is the threshold line, the DRN, and the threshold cycle. And we are going to see them in the amplification plot. What's called the amplification plot, we can see curves on the machine. Okay, the amplification plot here shows the threshold line. This is the threshold line, okay, where the emission starts to occur. And as we measure the threshold line, we can measure as well the quantity. The second thing we said that we use for quantitation, and we do all this together in the same setting, the DRN. The DRN is the difference between R1, which is the threshold line, and Rn negative and Rn positive, and this difference is the D delta Rn. The difference between them is the amount of copies. And the third one is the threshold cycle, which is very important and sometimes written in our reports, the CT. At what CT we got the result, because it denotes the amount of the original copies. Yani if we get a CT of 24, it is a low amount. If we, or 24, if we get a threshold a threshold cycle for 34 or 40, it is a big amount. Okay, and as we see, this is the threshold cycle where the emission cuts the threshold line. This is the CT. And we can use two types of quantitation. Absolute quantitation, we measure the copies, or the amount of the copies related to a PCR signal to a standard curve. We have a standard curve and we relate it to the amount. And this is used for the viral load. I'm going to show you a graph about this. And the relative quantitation, we use a standard control gene and another gene, okay? So we measure the targeted gene and relate it and correlate it to a control gene. And this is used for gene expression studies. This is what is absolute quantitation, which can use for microbial load or viral load. We use here the cycles, as we see, and this is the threshold line, and this is the lines, and each line with its color denotes a quantity. As we see that the color beige is for negative, the red one is for 10 copies, and to reach to the other red one in the other side for about 1 million copy. This is the absolute quantitation for viral load quantitation. We have special types of PCR. We have a multiplex real-time PCR. We use the same technology, but instead of putting one primer, we put a lot of primers to detect a lot of pathogens. Yeah. Okay. A reverse transcriptase real-time PCR. We use usually the PCR depends on detecting DNA, but in reverse transcriptase, we reverse DNA to be RNA, then we do the step of the PCR. So it is a reverse transcriptase. There is a lot of advantages for real-time PCR. It is allow quantitation, no post-PCR processing of products, and this advantages is correlated to the old conventional method, because the old method, we process the products of the PCR with a lot of contamination and a lot of false positives. So it is an advantage for the real-time PCR, and it is high throughput, low contamination risk, and it is rapid. It can happen in 2 hours. It can measure a wider dynamic range, and it confirms a specific amplification by another melting point analysis. That melting point analysis, we melt the products, we decrease the temperature and we measure the annealing of them, because when we decrease the temperature, annealing occurs, and we measure again the type of the annealing. Okay, it is most specific, sensitive, and reproducible. Disadvantage: it is expensive. Limitation هو هيقفل بعد لسه في كتير. في طبعا limitation في الجهاز، لان الجهاز ممكن يكون مش موجود. اوكي، ده بقى الخاصه بالاتش بي في. ان الاتش بي في ممكن استخدم له I can use for it specific types. We modified these basic concepts that I have showed you to make some types specific for HPV. First of all, we can use signal amplification system. Signal amplification system comprises that we put a lot of genes, a lot of primers, high risk and low risk types of human papillomavirus, and signals whenever a high risk is present. But it doesn't allow us for typing. We don't know the type, but we know that there is a high risk. So it is not recommended. The other type is for target amplification, which is we use real-time PCR. As we said, it is specific. We know the specific type and the reverse transcriptase PCR. And the other types or the other groups, by using the amplification products, we bring the products and we process them to do restriction, fragment length, polymorphism. In simple, this method depends on using enzymes that cut the DNA on mutation parts, and then we use probes to detect these mutations. The other type is hybridization analysis of PCR products. It as well uses specific probes to detect the PCR products. Microtetraplate, it uses a biotin labeled primer, that we put a primer that is labeled, okay, and then it attached to the target gene, and again we put an oligonucleotide probe to detect this biotin labeled primer. Plate direct sequencing, ان احنا we bring the PCR products and we do a direct sequencing on it. We see the genes and know the sequences, but it is a very expensive method and use it for research up till now. Reverse hybridization, it is in the form of strips. This strips, as we said, that we put يعني في حاجة liquid phase وفي حاجة solid phase. We have the solid phase, which is our kit, which is in the strip, okay? The definite primer, and we put the PCR products on it, okay? And detected by this can be detected visually on the strip, okay? And this is I summarized all this in simple. And we can detect the screening and progression prognostic biomarkers like human papillomavirus viral load and human papillomavirus messenger RNA and human papillomavirus integration E2 and E6-7 ratio. The clinical utility, it is just we have to make sure we have the valid sample. and the valid transport and storage for the sample. And we must correlate the detected products to the clinical condition of the patient. And the method should be validated. When I use any PCR or molecular method, I should validate the method because the risk of contamination is very high because our hands containing a lot of DNA. So the environment should be very clean and very sterilized to avoid contamination. conclusion اللي هو to relate the human papillomavirus detection genotyping with the clinical outcomes. Thank you. ما حبيتش أطول بس.
Thank you very much. You tackled a very, very difficult subject.
Yes, yes, it is very difficult.
And I can see you're very passionate about it as well. Just one question.
Yes.
Is there a limit to the number of primers you can use to detect by PCR techniques? So when we're trying to do it as part of a screening program, can we detect multiple primers at the same time?
Oh, this is a very good question because about multiplex PCR, it is the era of the multiplex PCR in the form of BioFire and the other platforms like GeneXpert. Actually, in BioFire, for example, the most أكتر حاجة كانت إيه 35. There was 35 pathogens in one well. 35. On asking the manufacturer or the company, we need more and more targets, they said we have to validate because the maximum point they reached was 35, giving a good result, which the FDA approved the platform on it. But when they increased the pathogens, a lot of false positives, and sometimes the targets, they anneal with each other, so that it gives a false positive result. So the maximum number they reached was in the pneumonia BioFire for detecting viruses and bacteria and atypicals. It was 35 pathogens, and they were clear about it. At the time being, they are making development on how to increase the targets because it's going to help for promoting their kits. But they have to be clear about it and to have the highest and the maximum benefit for the patient.
Yeah, I think it's very important to know that because as part of our screening program in the UK, we, at the national health level, we only detect a few, the most common high-risk HPVs. But if you go to the private laboratories, you get a report which is half a page of all the high-risk types that they've detected. So I guess it's possible maybe with multiple assays. I'm not sure how they do it on the private side. But, and the problem is that the number is always increasing, isn't it? The high-risk numbers.
Yes.
There was a time in the early 2000s that even between two lectures, a new high-risk HPV was detected.
Yes.
So at least I think we now have reached a sort of a finite number for that. Thank you very much for your
Thank you,
talk.
and I would like to add that while I was preparing the lecture, the previous kit that was used, it was detecting 37 genotypes. But nowadays they lessen the pathogens to only 28, which gives the maximum benefit and the optimum benefit for the patient. Thank you. Thank you.